So with increasing evidence of age-related conditions in people living with HIV, there is now a greater need for us to shift our focus of care to one that is away perhaps from looking at just viral load and CD4 to outcomes that are more person-centered. And we've heard a lot about this throughout this conference. In the literature, there are multiple models of integrated care that have been described. In high-income settings, many HIV programs have gone on to integrate comprehensive geriatric assessments as part of routine care, or at least some components of it, like assessing frailty and so on. But this has been more challenging in the low-middle income setting where we have limited access to this expertise. At best, I think in the LMIC setting, what our programs have evolved to is to include intensified disease-based monitoring, looking at monitoring diabetes, hypertension, dyslipidemia more closely, and some centers have started to include mental health services as well. Now, one alternative integrated model of care that has not been very well studied in the context of HIV is a model that was introduced by WHO in 2017. And this is based on the Integrated Care for Older People framework, which proposes that we monitor or we measure intrinsic capacity in individuals as part of routine care. And intrinsic capacity is a construct that is centered around an individual's functional ability. Now, intrinsic capacity comprises of all of the physical and mental capacity that an individual draws on a day-to-day basis for them to function. And it can be operationalized by measuring 5 domains. And these are mainly mobility, vitality, sensory, both hearing and vision, psychological health, and cognition. Now, in the last 2 to 3 years, there have been a number of publications and studies that have been done in the general older population that have found that that have validated this construct and found it to be predictive of mortality, disability, and frailty. And many of these studies have actually been done in countries in the Asia-Pacific region. But the utility of this construct in the context of people living with HIV has not been studied well. So to address this, we recruited about 189 people living with HIV who were returning to our clinic as part of routine care, as well as 89 community dwelling controls. The inclusion criteria was 35 years and above. Our patients had to be on stable antiretroviral therapy for at least 12 months, and controls had to have a negative test, HIV rapid test prior to recruitment, and both of the groups were age matched. There were a number of indicators that we assessed for each of the domain to decide whether or not a person was deficit in a certain domain. For cognition, we assessed this using MOCA. For sensory, we assessed it during 2 functional questionnaires for vision and hearing. Vitality, we assessed nutrition, grip strength, waist circumference, and elevated inflammation. Mobility, we assessed gait speed. And depression, we assess, mood, we assess depression, anxiety, and stress. And if an individual had an abnormal screen for any one of these indicators, they were given 1 point for that particular domain, except for sensory, where we counted this as 2. If you were abnormal for vision and abnormal for hearing, then you got 2 points. So in the end, we calculated a composite intrinsic capacity score for each individual, and this could range from 0, which means you didn't have any deficits, to 6. That means all of your domains were impacted. And there was also a range of other parameters that we measured in the constructs of physical, psychosocial, clinical, as well as quality of life. Now, with a total of 155 people with HIV who had a complete assessment for all of the domains that we could include in our analysis, and 89 controls, and the median age in both groups was 50 years. Now, when we looked at the deficits of the intrinsic capacity by domain, what we found was that the frequency of people with HIV with deficits was higher for cognition, vision, mood, and vitality, but this was only significant in for the domains of cognition. And when we looked at presence of multiple deficits, there were twice as many people with HIV with 2 or more deficits occurring compared to controls, which indicated that these deficits tended to co-occur. And we tend to see this with geriatric syndromes as well. Now, when we looked at the average chronic comorbidities by intrinsic capacity score, we see a significant positive correlation where the higher your score, the greater the number of chronic comorbidities. And we saw the same pattern both in people with HIV and controls. And we looked at IEDL scores, and the higher the IEDL score, the greater your dependence. We also saw a significant positive correlation both in people with HIV and controls. This correlation matrix shows the age-adjusted correlations for intrinsic capacity in the first column with the range of different health outcomes that we assessed in the cohort. And on the second column, we did the same analysis with VAX index. And as you know, VAX index is a pretty established composite score which utilizes clinical markers, and in multiple studies has been shown to be associated with poor health outcomes in people with HIV. Now, apart from falls, all of the other health outcomes assessed was significantly correlated with intrinsic capacity score, but we didn't see this with VAX index. And similarly, in terms of strength of correlation, and that's shown by the darker red or the darker blue boxes, we see that there was a stronger correlation with intrinsic capacity scores with the different outcomes compared to VAX index. Intrinsic capacity scores also showed a good ability to identify frailty in people with HIV. And on the left, we see that the AUC is 0.87, and this is when frailty is measured by frailty, the Fried's frailty phenotype. And on the right, the AUC is 0.79 when frailty is assessed using Frail scale. So in summary, intrinsic capacity scores are a good composite measure of physical and psychosocial functioning among people with HIV on ART, at least in our setting. And the measurement of IC provides an opportunity for us to integrate functional assessments as part of routine care and complement what we are already doing in terms of disease-based monitoring. And because these assessments measure capacities for very functional aspects, like how do you, difficulties in seeing, hearing, your mood, it really embraces the concept of person-centered care. One of our limitations is our sample numbers, or our sample size was smaller than what is usually needed for these type of validation studies. But as an early study, I think the findings that we got are very promising for us to take this work into a larger cohort and perhaps in a more diverse setting. I'm presenting this work on behalf of our team who work very hard and very capable. I'd like to thank them and acknowledge all of their work, as well as our funders. Thank you.